Now, I'd like to invite our next speaker, who is like to introduce her. She's Dr. Nida Ul-Huda Adznan. She's an acute internal medicine physician from Hospital Selayang, and she will bring us through from stable asthma. We're now moving to asthma exacerbations and appropriate referral in primary care. So with that, I'd like to invite Dr. Nida to.
Yes, Assalamualaikum warahmatullahi wabarakatuh, and very good evening to all. Thank you, Dr. Prof. Andrea, for the kind introduction. Thank you to Mahtas and MMA for organizing this webinar. And today I will be discussing a very practical and important topic in primary care, which is asthma exacerbations and appropriate referral. So asthma is a common condition that we manage almost daily. However, when patient deteriorate, the window for effective intervention can be very short. And many poor outcomes are actually not due to lack of knowledge, but more of due to delay in recognition or treatment. So today, I will be focusing on what really matters in our clinic setting, how to act early, treat effectively, and recognize when a patient needs urgent escalation. Okay, so today's focus is on the 5 key priorities for exacerbation and management in primary care. By the end of this session, you should be able to recognize an asthma exacerbation quickly, identify high-risk patient, and also perform a rapid but effective assessment, as well as initiating immediate treatment, including our SABA, as well as systemic corticosteroids. So equally important, we should be able to confidently identify red flags that require urgent referral and ensure safe discharge with appropriate follow-up if patient improve clinically. So this entire session will be built around these 5 key priorities. So an asthma exacerbation is actually defined as a progressive or sudden deterioration of patient's symptom from their baseline. Patient may be presented with increasing shortness of breath, wheezing, chest tightness, or persistent cough. And these symptoms are actually a reflect of underlying airway inflammation as well as bronchoconstriction. So the key point here is that asthma exacerbation is a clinical diagnosis. You do not need to wait for peak flow measurement or even your blood test or imaging before starting treatment. So whenever we see a patient with asthma exacerbation, it is crucial to ask ourselves whether they fall into a high-risk category. So these high-risk patients include those with history of previous intubation or ICU admission, if they have frequent hospital visits or hospitalizations, including ED visits, overuse of reliever or inhaler, and also poor adherence to inhaled corticosteroids. These are the patients who are particularly vulnerable, and even if they appear stable initially, they can actually deteriorate rapidly. And recognizing this group early should actually lower our threshold for aggressive treatment and referral. So in primary care, our assessment must be rapid and focused. The key principle is actually simple. Do not delay treatment for a detailed history. So we can always refine our assessment later, but the initial management must not be delayed. So our vital signs, especially our oxygen saturation, should be checked immediately. We should also quickly assess the patient's ability to speak and their level of consciousness, and signs of respiratory distress such as use of accessory muscles. So a very important clinical indicator is speech. If a patient is unable to complete full sentence, we should actually consider that this is severe exacerbation until proven otherwise. So I'm going to bring all of you to this algorithm tree, which we already presented in our asthma CPG on the management of asthma exacerbation in primary care. So the components that we are going to assess will include conscious level, speech, respiratory rate, pulse rate, blood pressure, accessory muscle, breath sound, SpO2, as well as ABG if it's available at our respective center. So we'll first focus on the mild exacerbation, whereby patient will be alert, having a normal vital signs, and the only two things that may be abnormal is the presence of wheezing, as well as use of accessory muscle. So for the moderate asthma exacerbation, patient mainly will remain alert with a normal blood pressure. However, the vital signs have all become abnormal. The respiratory rate will increase. The heart rate will start becoming tachycardic. Patient may speak in phrases, and the SpO2 will start to be between 90 to 94%, and it will show abnormality in your PaO2 as well as PaCO2. So for a severe asthma exacerbation, you may have a patient who is still alert, or they may actually become confused or drowsy. They'll be speaking in words. There will be worsening of the vital signs, including either a normal or hypotension of the blood pressure. There will be evident use of accessory muscle, worsening of the wheezing. The SpO2 may be less than 90%, and a even worse reading with a PaO2 of less than 60 millimeter mercury and a PaCO2 of less than 40. So for life-threatening asthma exacerbation, patient may be confused, drowsy, or in coma. They may not be able to speak, and you will see a lot of paradoxical in the vital signs, including a bradypnea, bradycardia, or even cardiac arrest, hypotension, paradoxical chest movement, or even an absent chest movement, a silent chest on auscultation, an SpO2 of less than 90%, and you will start to see not only type 1 respiratory failure, but they will start to have CO2 retention, showing evidence of both low in PaO2 and high in PCO2, or a type 2 respiratory failure. So priority 1, which is the most important principle in asthma management or asthma exacerbation, is that the treatment must be started immediately based on clinical severity. You do not need to wait for objective measurement if the patient is clearly in distress. So rapid clinical assessment of the severity is actually sufficient to begin, especially all the life-saving therapy. So in primary care, you have these 3 main treatment tools. First is our short-acting beta-2 agonist. This is our first-line treatment. And in mild to moderate cases, a pressurized metered dose inhaler with a spacer is actually as effective and preferred over a nebulizer. Of note, remember that oral SABA should never be used for exacerbation due to systemic side effects. So a no to oral SABA. Second is the oxygen therapy. This should be given if the patient is hypoxic with a target saturation of at least 94%. And third, and very importantly, is the systemic corticosteroids, whereby prednisolone of 0.5 to 1 mg per kilogram up to maximum of 50 milligram. So one structured approach you can use in the 60-minute SABA stacking cycle, where you repeat doses every 20 minutes and reassess after 1 hour. So the SABA must be continuously be driven by oxygen with a strict 20 minutes interval. So, for example, we give an initial SABA dose plus our stat dose medication. We wait after 20 minutes and repeat the SABA dose, and then wait another 20 minutes, repeat another SABA dose, and then only at 60 minutes after the completion of 1 hour cycle, we re-evaluate the patient clinically and decide on the clinical trajectory. Systemic corticosteroids are the cornerstone of asthma exacerbation management. They actually reduce airway inflammation and accelerate recovery, and most importantly, prevent relapse. Steroids should be given early in all patients with an exacerbation. And oral administration is just as effective as intravenous and is actually more practical in clinical setting. So a typical duration is actually 5 to 7 days, and tapering is actually not required. So a key mistake to avoid is actually withholding steroid, and this actually significantly increases the risk of relapse. So this is the continuity of our algorithm tree, whereby in mild cases, as I've mentioned, we have SABA, prednisolone, as well as control oxygen if indicated. Similar, in moderate exacerbation, we give similar treatment, but what is important is after 1 hour, we need to reassess. And the 1 hour mark is the key decision point. We should evaluate whether patient's symptoms have improved or whether their oxygen saturation has normalized. If the patient shows clear improvement, we may consider discharge with appropriate precautions. However, if there is no clinical improvement or if the patient deteriorates, this is an indication for escalation and referral. So always look at the overall trend rather than relying on a single measurement. So one of the most important roles of primary care is recognizing when a patient actually needs urgent referral. You should refer immediately if the patient has severe or life-threatening features showing no improvement after initial treatment or deteriorates at any point. So other indicators include excessive SABA use prior to presentation, example of use of more than 8 puffs of SABA prior to presentation to your center. And while waiting for transfer, treatment must be continued. The key message is not to wait passively. Active management must continue while arranging for transfer. So in severe or life-threatening exacerbation, management must be aggressive and immediate. Just now, when we talk about mild and also moderate asthma, we talk about the 3 tools. However, for severe and life-threatening asthma, we have these 5 pharmacological arsenal, whereby we start with oxygen-driven nebulized bronchodilator. We also add on ipratropium bromide bronchodilator. We may add on actually ipratropium bromide together, and at the same time, arrange for an urgent transfer to the nearest hospital. We have to ensure that oxygen should be delivered with a target saturation of more or equals to 94%. We may consider given IV hydrocortisone 100 mg IV stat if they are not being given prednisolone before. And the final one is giving IV magnesium sulfate of 2 grams through an IV infusion over 20 minutes as a single dose. This is something that we have add on in our CPG for the primary care management on asthma exacerbation. The principle here is to stabilize the patient while preparing for transfer and not to delay one for the other. So this is the algorithm for our acute asthma management for severe and life-threatening category. This is the 5 pharmacological arsenal that I have actually mentioned before. And if you notice here, if patient does have clinical improvement, we have to continue treatment during transfer and monitor progress. However, with the patient actually showed no clinical improvement after treatment with the 5 pharmacological arsenal, we need to consider intubation if the patient conditions deteriorates. Okay, so if the patient presented with life-threatening asthma even at the presentation, please do transfer to the nearest hospital immediately. So discharge should only be considered when the patient has clearly improved. However, safe discharge actually involves more than symptoms resolution. And you must ensure that the patient actually receive a full course of oral steroids, has their inhaler technique checked, and also understands their medication. An asthma action plan should be provided or updated, and follow-up must be arranged within 1 to 2 weeks. Failure to address this aspect is a common reason for relapse and readmission. So beyond the acute episode, long-term management is essential. This includes patients' education, trigger avoidance, education on self-monitoring, a regular review, arrangement for regular review with scheduled periodic checkups to assess control, adjustment of treatment, as well as update on the asthma action plan. And a good primary care management can significantly reduce further exacerbation and improve quality of life if we also emphasize on the lifestyle modification. So integrate these pillars into our routine care to improve long-term outcome and quality of life. So to summarize, asthma exacerbation management in primary care revolves around 5 key principles: assess rapidly, act decisively, ensure we give steroids early and to all patients, recognize when to refer, know our own limits, and ensure safe discharge and follow-up. If there's one takeaway message, it is this: early action saves lives. With that, I thank you.
Thank you very much, Nida. I think that was very comprehensive. Also, the pictorial actually helps us to understand something and make something difficult sound easy, right? So I think we're all smarter now before and after Nida.